Hey guys, so welcome back to it. Today marks a transition into a new unit within Health Psych, and specifically this unit is going to be more focused on various medical conditions. So first up, we've got two big ones. We've got cardiovascular disease and diabetes. So broadly speaking, this chapter is focusing on cardiometabolic diseases. And so what we're going to do for each of these is first we'll just kind of briefly introduce the organ systems involved in the particular diagnosis, then what's going wrong with those organ systems that's kind of creating the circumstances for disease, and then we'll move into biopsychosocial types of perspectives in terms of talking about causes, and then finally we'll wrap up talking about treatment. Okay. So up first, let's talk about some basic anatomy and physiology relating to the cardiovascular system. I present this information and I say this information is for MHPs or mental health professionals because I know those of you from an exercise science or nursing background or those who are thinking about any of the pre-health fields that you guys are taking very thorough in-depth anatomy and phys classes, but that's not necessarily something that psych folks might be taking. And so I want to make sure that at minimum, everybody's got at least a really basic idea of what's going on within the body that's setting the stage for some of these diagnoses. You'd be surprised as a mental health professional the number of times that I've had to walk a patient through in layman's terms what's happening with their body physiologically, because that might not be information that they're necessarily getting from a physician or a PA or a nurse in a more traditional healthcare setting. And whether they're not getting that information for timing reasons, or a provider just assumes that a patient is more informed than they are. We've talked about patient advocacy issues and things like that in this class before. But again, regardless of the reason, if you're going to be working with this stuff, whether it is on the physical or the mental health side, it's important to know about the pieces on the other side, because again, you'd be surprised the number of times that you might be talking about that other side to a patient. And that goes both ways. So even if you're thinking about working more on the physical health side of things, it still is important to know basic stuff about things like depression or anxiety, or different terms for various therapeutic approaches, because again, you never really know what you might end up talking to a patient about. So, cardiovascular system, it's comprised of the heart, our body's blood vessels, and the blood as well. A lot of people don't really think of blood as being part of the system. They think of it as being, this entity that exists within the system. But blood is actually living tissue as well, so it's considered to be, an active component of the system. As far as your heart itself, it is about the size of your clenched fist. It weighs less than a pound. It's a very muscular organ, and it pumps more than 5 quarts of blood a minute through the body's circulatory system. The circulatory system is a component of the cardiovascular system, and it's basically just a term that refers to the circuitry of blood vessels that's running throughout the body, carrying blood from the heart out to those organs and organ systems and body parts, and then kind of back to the heart in turn. At the end of the day, our body's cardiovascular system is our body's transportation system. So that's what makes the system so important, is that without this system, our body wouldn't have a way of getting access to the oxygen that we breathe in or the nutrition that is absorbed from our food. Or on the flip side of that, there would be no way to remove waste. So that is ultimately what our cardiovascular system is responsible for doing. There are 2 different types of blood vessels, broadly speaking. Again, this is very, very basic anatomy and phys, but broadly speaking, 2 different types of blood vessels. We've got arteries and veins. Arteries are carrying usually oxygenated blood away from the heart to various body parts, whereas veins are carrying that deoxygenated back to the heart, where that blood will later pick up more oxygen from the lungs. The heart itself is comprised of 4 chambers that pump blood to the lungs and body. So I'm not going to kind of drill into you guys the specifics of the various chambers of the heart or what chambers are carrying oxygenated or deoxygenated blood. If you've taken an anatomy or phys course, I'm sure you've gone over this information. For the intents and purposes of this class, you guys just need to know that blood acquires oxygen from the lungs, and once it's picked up that oxygen, the blood then goes back to the heart where it's pumped out to the rest of the body. The blood then returns from the body back to the heart before going back to the lungs, and so on and so forth. So blood basically alternates between going out to the body and the lungs, and blood kind of checks in with the heart between each of those steps. And then the muscular heart is ultimately what's responsible for pumping that blood out and providing the pressure needed to propel the blood out to its various destinations. The one specific thing that you should know anatomically about the heart is that's the left half of the heart that's responsible for pumping blood out to the body. The reason that's important to know is that when you think about it, the body is much larger, and, blood's having to travel a further distance to get to your extremities, like your toes, your fingers, your head, compared to the relatively short distance it takes blood to hop on over to the lungs. And so because the left part of your heart is responsible for pumping this blood out to your entire body, it's this part of the heart that is more muscular. It's also this part of the heart that's going to be strained more if you have blockages. So if you've got blockages in the arteries that are leaving the heart and taking blood to your legs, to your arms, up your neck into your brain, that is going to increase the pressure on your cardiovascular system, meaning that the heart is going to have to pump that much harder to force the blood through despite there being blockages. And so one thing that we might see in that scenario is something called left ventricular hypertrophy. This is a fancy way of saying that the left ventricle of the heart has become fat and enlarged, and so that's the area that I've drawn a little square around to kind of highlight that the pink muscular wall is thicker for that part of the heart. And in a healthy heart, normally this part of the heart is going to be thicker, but sometimes it can get extra thick as a consequence of becoming extra strong to pump this blood out past blockages, and that can be a risk for heart disease at the end of the day. How blood pressure works is it's actually measured as a fraction between blood pressure at different points in a heart contraction, which is why it's typically relayed as a fraction, so one number over another number. There is such a thing as mean heart rate or as mean blood pressure, but it's not a number that's referenced quite as frequently, at least in terms of health measurement. The number that, again, we use in terms of describing a person's health and whether they have a healthy blood pressure or they're pre-hypertensive or hypertensive is a fraction. And ultimately, the number on top is reflecting the pressure in the entirety of your cardiovascular system when the heart is contracted and all of the blood in your body is existing outside of the heart, versus the number on the bottom is when the heart is refilling. And so as a consequence, the pressure is going to be relatively less. So normal blood pressure is considered to be 120 over 80, pre-hypertensive is 130 over 85, and hypertensive is 140 over 90. And as far as those diagnoses of pre-hypertension and hypertension go, typically you're going to receive the diagnosis if just one of those numbers is high. So if, for instance, a person had a blood pressure of 140 over 85, they would be considered hypertensive, not pre-hypertensive. And so ultimately, we're going to be diagnosing a cardiovascular disease when a blood vessel is impeded beyond a critical point, and the likelihood of blood getting through efficiently goes down. So at that point, the either cardiovascular disease is diagnosed or the risk of a cardiovascular disease is going up substantially. This is, the most common health diagnosis in the United States. It impacts 60 million Americans and accounts for about a third of all deaths in the United States. Cardiovascular disease in and of itself, though, is an umbrella term. It's not referring to a particular blockage in a particular area. And so instead, under this umbrella term, we've got various diagnoses that are referring to different blockages in different areas. So for instance, a stroke or a cerebrovascular disease would be a blockage in one of these cerebral arteries that's supplying blood to the brain. And a coronary heart disease would be a blockage in one of the coronary arteries that is supplying blood to the heart. And that can be one of the more dangerous diagnoses because if blood is having a difficult time reaching the exterior of the heart to supply the heart itself with the oxygen and energy it needs to continue pumping, this then could threaten the heart's ability of getting those things out to the rest of the body. There are several different dietary precursors to heart disease, and so I will kick off our discussion of some of the causes and physiological markers of heart disease by talking about the impact of our diet on this particular diagnosis. So fats are going to be the big kind of macronutrient group that is relating very strongly to heart disease. The big type of fat that is really, really dangerous is going to be trans fat. Trans fat are hydrogenated oils that are basically used to enhance the shelf life of packaged and processed foods. So they are artificial manipulated substances that, like I said, are basically allowing food to sit on the shelf longer. They're not necessarily a bad thing simply because they're man-made. I do just want to tie that back to our discussion of the whole natural myth that we went over in terms of talking about nutrition more broadly. They're bad because they have a negative impact on human health. A second type of fat to look out for is more saturated fat. Saturated fat is fat that is solid at room temperature, like animal products, butter, anything if left sitting out on your counter or even in your fridge is going to turn solid versus existing in a clear liquid form like an unsaturated fat, which you would find in the form of oils and things like that. The US government actually acknowledged trans fats as being exclusively across the board dangerous, bad for health, no benefits except for to help packaging companies create a product that would last forever. But as far as human health goes, absolutely no advantages. And so trans fats were actually banned from the United States in 2015. And companies were given until 2018 to work trans fats out of their recipes. And 2019 was given as kind of a secondary deadline for companies that couldn't make the initial deadline. So as of this point, you may still see trans fat on nutrition labels if you're looking at, the back of a product you're consuming. But at this point, you should be seeing zeros in terms of actual trans fat within products. The real reason that fats are important to attend to in terms of assessing cardiovascular risk is because fats become cholesterols once they've been ingested. And this in general is a healthy process. All cholesterols aren't bad. Cholesterols are created from fats for a reason. Some of the things that our body uses cholesterol for is going to be kind of structural pieces, like cholesterol, for instance, plays a role in forming the walls of our cells. Beyond that, cholesterol also plays a role in myelinating our brain cells. Myelination basically means that a part of each brain cell, or not each, but myelinated brain cells have a component that is basically wrapped in cholesterol, and that cholesterol wrapping helps brain cells to communicate much more quickly. For instance, a myelinated brain cell can communicate a message at about 200 miles per hour versus an unmyelinated brain cell can only communicate at a rate of about 2 miles an hour. So there are unmyelinated cells in the body, but it's tremendously important to have myelinated cells, and our body gets that cholesterol from fat. In terms of measuring fat, or not measuring fat, measuring cholesterol, there are a couple different markers we can kind of reference. One would be total cholesterol. Total cholesterol is sometimes referred to as dietary cholesterol or serum cholesterol. They're all synonyms, so just kind of recognize that if you see any of those, basically they're all referring to the total amount of cholesterol in the body. And generally, we are looking if total cholesterol is exceeding 200 milligrams per deciliter, that is going to be a risk factor for heart disease. If LDL or triglyceride levels exceed 100, that's also going to be a risk for heart disease. And if HDL is under 40, that is going to be a risk for heart disease. So LDL and triglycerides are sometimes referred to as the bad cholesterol. You may have heard of that terminology, even if you haven't heard of these particular phrases before. So that's why we're looking for those numbers to stay low versus high. HDL is what's referred to sometimes as good or healthy cholesterol, and so we actually want that number to be higher, and so it's considered to be a risk if that number is too low. One of the reasons that HDL or good cholesterol is considered to be a healthy thing is because it is more effectively worked out of our body. It also plays a role in kind of ushering the bad cholesterol out of our body as well. Whereas if left to its own devices, the bad cholesterols, quote unquote, tend to linger in our body past their usefulness. While cholesterol is popularly used as a marker for how sick a person is or how at risk a person may be for getting sick relating to cardiovascular diseases, inflammatory damage is actually a better predictor of cardiovascular risk than cholesterol levels. And one of the ways to assess for inflammatory damage is to measure for blood levels of something called a C-reactive protein. One of the reasons that inflammation can be a better marker than cholesterol is because blood cholesterol levels can be impacted by a variety of things. They can be impacted by what you're consuming, they can be impacted by physical activity levels, but they can also be impacted by things like family history and genetics as well. And so you'll have people sometimes who just have a really poor family history and who are active, but their cholesterol levels are maybe still a little high, and it has nothing to do with their behaviors. It's really more associated with family history. And so those folks seem to be at a less of a risk than folks with higher levels of cholesterol who maybe are completely sedentary or don't eat well, but for genetic reasons, their cholesterol is low. And so cholesterol can be a bit of a misleading number. And inflammation, the reason that can be something that's more helpful to attend to is because inflammation is a marker of what is actually going on in the body. So to understand that a bit more, let's talk about these two terms on this screen, atherosclerosis and arteriosclerosis. These are basically the two consequences of cholesterol in the body. So atherosclerosis is the accumulation of plaques, cholesterol, fats along arterial walls. And you can see that represented in the graphic on the right-hand side of the screen, the yellow buildup that is preventing blood from efficiently getting through arteries. There are several causes of atherosclerosis in addition to what a person's been consuming. One such cause is repeated stress. Unsurprisingly, if a person is stressed out, that's going to contribute to chronic hypertension. And we talked about the links between stress and blood pressure way back, I think it was in chapter 4. So if you need a refresher, you can reference that material. And that hypertension, what it does is it causes damage at the bifurcations of the body's arteries. Bifurcations are when a large artery splits into two smaller arteries, and so the blood is kind of slamming up against this breaking point before kind of splitting into the two kind of smaller pathways. The reason that high blood pressure can contribute to damage is because if blood pressure is higher, that means the blood is moving more quickly and it's going to be slamming into that bifurcation much harder before splitting off. And that slamming of blood is actually causing more damage. And so that damage that's been caused, those bifurcations, initiates that inflammatory response. So again, we've kind of already talked about that in this class as well, in the context of stress, that, when damage is caused, the body's immune system kind of acts, it seeks out that damage, and the inflammatory response is aimed at kind of healing that damage. So how does our body actually do that? What does your body do to address damage that's been done from fast moving blood? Our body's solution is to begin circulating fatty or foam cells, which are basically like these fatty band-aids. And so the body's trying to cover the damaged bifurcations with these fatty band-aids to protect the arterial walls from further damage. But of course, that buildup is just contributing to higher blood pressure and more damage going forward. So it's kind of like this vicious cycle. Beyond that, another consequence of stress and the activation of the sympathetic nervous system, or the body's fight or flight, is that epinephrine is going to be released into the blood, which also circulates platelets. So that's something else in the blood that has the potential to do damage and to kind of cling on to arterial walls and kind of gunk them up. Beyond that, of course, another thing that happens when we're stressed is energy is being mobilized, meaning that we have an excess amount of fat, glucose, LDL in our blood. So this is all just extra stuff that, again, has the potential to either do damage or contribute to gunk buildup. Arteriosclerosis is the hardening of arteries, and in large part, this kind of happens in or as consequence to our atherosclerosis. Basically what happens is vessels build thicker muscle to handle the chronic rise in blood pressure, which would kind of be analogous if we kind of think of the body's arteries and blood as like water rushing through a hose. It's like the hose is getting more out of control, the pressure's rising, and so what do? We clamp down on that hose harder to try and control it. But what happens in the body when we do this is, as that muscle kind of hardens the vessels, they become stiffer, which contributes to more blood just bouncing around all over the place and doing more damage. And then that damage causes the inflammatory response and those fatty cells, which leads to thicker muscle and so on and so forth. So there's kind of a vicious cycle here between all of these processes, where once one starts, again, it's kind of like what we talked about with the stress response. It's just very difficult to kind of turn it all off because it's all kind of reinforcing itself. So what are some of these specific diseases that are caused by this process that exist under the umbrella of CBD? One that we mentioned earlier is coronary heart disease, or CHD. This is a chronic disease in which the arteries supplying the heart with blood become narrowed or clogged. A more specific symptom or diagnosis that we might see relating to that diagnosis is something called angina pectoris, or sometimes it's just referred to as angina in general. Angina is going to be chest pain. And what's happening here is that typically when we are stressed out, what happens is blood flows more to our muscles, our heart, our brain, as part of that fight or flight to kind of help us deal with that stressor. And so typically when we're stressed, the coronary artery dilates and allows blood to get where it needs to go. But ironically, when a person's been chronically stressed by work, by their relationships, whatever, when a person's been chronically stressed by a psychosocial stressor, what happens is that then when we add an acute new stressor on top of that, like getting stuck in traffic or yelling at a partner or something like that, that acute new stress actually starts to cause vasoconstriction instead of vasodilation, which means that rather than blood rushing through the coronary artery to the heart, that the coronary artery gets smaller, so it's harder for blood to get through. And that's what causes chest pain. And so this angina is something that you'll frequently see in people who are chronically stressed and who already have some damage to their heart. And so when they are acutely stressed, they feel this chest pain because the blood is having a difficult time getting to the heart. Another diagnosis that relates more broadly to CHD is something called a myocardial infarction, or an MI for short. This is when the coronary artery is completely clogged and blood cannot get to the exterior of the heart. This is also what we refer to as a heart attack. What happens if enough time elapses is permanent death of heart tissue occurs, and this begins to happen within seconds of a complete obstruction. So time lost is tissue lost is a really popular saying within the heart disease community, that it is absolutely critical to intervene quickly, because the longer you delay, the more tissue is going to die as a consequence. Typically, the reason for a heart attack is that a plaque has ruptured further back in an artery. So blood was previously getting around this clot, but because part of it ruptures and breaks off, that piece of clot floats further down the artery to where the artery is smaller, and now it's kind of stuck and blocking, which is frequently why heart attacks kind of happen very suddenly. So that thrombus, or that clot that is broken off, has gotten stuck now and is either reducing or obstructing further blood flow. A stroke is kind of like a brain attack. We don't call it a brain attack, but that's basically what it is it's the same thing as a heart attack, but instead of blood having a difficult time getting to the heart, blood is having a difficult time getting to the brain. And depending on where in the brain the blockage is, that is going to play a role in what the damage of the stroke is. There are several different types of strokes. We have ischemic strokes and hemorrhagic strokes. Ischemic strokes are the most common, and they're caused when an artery is obstructed. So same thing as what we talked about with the myocardial infarction. A hemorrhagic stroke is, instead of there being a blockage, a blood vessel is going to burst, and I've got that represented in this graphic on the screen. The blood vessel typically bursts due to high blood pressure and the blood vessel wall just being stressed or weakened over time. Sometimes hemorrhagic strokes may also be caused by aneurysms. And so either way, whatever the cause is, the blood vessel wall bursts and the person begins bleeding into their brain. But at the end of the day, the brain only gets oxygen when it is supplied oxygen through the arteries and the capillaries, not when blood is just sitting on top of the brain. And so the brain is covered in blood, but none of it is basically usable in this form. And so the brain is left without oxygen and also with increased cranial pressure on the brain. General effects include loss of speech, numbness, blurred vision, and paralysis. And damage is usually on one side of the brain, resulting in symptoms on the opposite side of the body. But again, the specific symptoms are going to depend on where in the brain the blockage is occurring. In order to make a diagnosis of a cardiovascular disease, there are a couple of different approaches we can use. And again, these are approaches that you're probably familiar with if you're coming to this class from more of a physical health background. But for those of you with more of a psych mental health background, it is important to be familiar with some of these terms, because you may have a patient telling you about their EKG, and it's important to kind of know what an EKG is, or the difference between like an EKG and an exercise or a stress EKG, so you can kind of follow along in conversation with them without a therapy session turning into you asking your patient a ton of questions about what's going on. So an EKG, or an echocardiogram, is a commonly used test for cardiac health. The spelling's a little funky because, of course, here in the United States, we have to do everything in a complicated fashion. And so we spell electrocardiogram in an American fashion with a C, but then when we abbreviate it, we like to use the English abbreviation, which implements a K instead of a C. So that's the reason for the difference there. An EKG is done when electrodes are attached to the body to measure electrical discharge from the heart. And so you can see an example of kind of a cartoonized graphic of an EKG at the top of the screen. These graphic representations are printed out, and they're representing normal or abnormal patterns of the heart. So you could see things like an arrhythmia, for instance, if a person's heartbeat wasn't regular and was instead kind of skipping beats. An exercise EKG is the same process. This is sometimes referred to as a stress test, but instead of doing the EKG while the person's at rest, you're going to have the person get on a treadmill to see what their heartbeat looks like while they are exercising. And this is done to see how the person's cardiovascular system responds to stress, i.e. exercise. So if a person experiences pain, i.e. angina, that would be a sign of underlying damage. Similarly, if a person has a difficult time recovering from exercise, that can also be a sign of underlying damage. The fact that the parasympathetic nervous system is not used to kicking in following activation of the commonplace sympathetic nervous system. An echocardiogram, or an echo sometimes for short, uses an echo of sound waves to create an image of the heart and reveal damage. So you guys can see that there in the middle of the screen. So you can see if, for instance, there is left ventricular hypertrophy, if that left ventricle of the heart is looking really large. Pictures are basically kind of the end result of the echo. A coronary angiography, or an angio for short. This is going to be the most accurate means of detecting coronary heart disease. Basically, what's done here is a catheter is threaded into an artery suspected to be blocked, and then dye is injected so that the artery and damage become visible when x-rays are taken. And so you can see in this bottom picture that those fat veins of dark black blood suddenly becomes smaller and really thin before puffing up again. And so you can see that the blood's pathway is kind of restricted by a blockage before kind of opening back up again. And so that's a good example of seeing what that damage actually looks like. As far as biological treatments go, there are several different approaches, broadly breaking down into the medication and surgery categories. Medications include nitroglycerin, which is used to stabilize the heart's electricity. Beta blockers are used to prevent a sympathetic nervous system response. Vasodilators, like Viagra, interestingly enough, was originally a heart drug before trials revealed it was also helpful for sexual dysfunctions. But vasodilators expand narrowed blood vessels so that blood can more easily get to where it needs to go. Anticoagulants like aspirin can be used to prevent clot or thrombus formation in the first place, and then thrombolytic agents are used to dissolve clots fast after there's been a complete blockage. Surgery options, broadly speaking, fall into two categories. We've got bypass surgeries and angioplasties. With a bypass surgery, a small piece of vein is going to be grafted around a blocked artery, and you can see that represented in the upper graphic on the right-hand side of the screen. So you can see how these additional pieces of vein are being used to bypass blood, kind of in the same way that if you're on the highway and you're heading into a big city, you might hop on the bypass to go around a city versus through a city. And then angioplasties are done via this balloon being inserted using a catheter, and this balloon is wrapped in this stent, and once the balloon and stent are in place, the balloon is inflated, and basically what this does is it puffs the stent up so that it's kind of mashing the plaque against the arterial wall, kind of like a pancake, and then the balloon is removed, leaving the stent in place, and again, you guys can see that in this graphic on the screen, and so the stent is left behind so that the blood can kind of safely flow through, kind of like creating a tunnel. At the end of the day, though, because cardiovascular diseases are so behavioral in nature and lifestyle based, yes, there's a genetic piece to them, but so much of heart diseases goes back to things like diet, exercise, and stress levels. If people do not adjust their lifestyle, these surgeries are only temporary in nature. About half of bypass surgeries reclog within 5 years without lifestyle change, and about a third of angios will reclog within 4 to 6 months without lifestyle change. So what are some of those other risk factors to be adjusted? First of all, I do again want to just kind of address and throw out there that there are plenty of uncontrollable risk factors that are definitely at play, and things to be aware of. So things like family history, more specifically, having a close male relative with a heart attack before the age of 55, or a close female relative with a heart attack before the age of 65 are going to both be high risk factors for heart disease. Being older is also a risk for heart disease. About half of people with CVD are over the age of 65. Men in general have a higher risk of being diagnosed with CVD, at least until average menopausal age. And this kind of indicates that estrogen may play a protective factor in women up until this point. From a ethnicity or racial point of view, African Americans are at a higher risk, and then Asian and Hispanic Americans are going to be at a decreased risk. And then as far as socioeconomic status goes, low socioeconomic status is associated with more controllable risk factors, things like less access to exercise, more psychosocial stress, less access to healthcare. So all of that is obviously going to play a negative role on health. You guys will find an article on As You Learn reviewing the effect of racially based stress on African Americans. And so we're going to talk about that as being kind of an avenue for that higher risk for that particular racial group in class. So what are some of the controllable risk factors, the things that someone would have to change, even if they were going through with surgery? Like I said, without changing these things, it's very likely that those arteries are just going to reclog later down the line. So what do we have to change? If a person's blood pressure is consistently above 140/90, this is considered to be hypertension. This is a very, very high risk factor for heart disease. Most cases are diagnosed as primary or essential, meaning that a specific cause isn't known. But general causal factors in most cases do, broadly speaking, include things like obesity, a lack of exercise, higher levels of dietary salt, and excessive stress. Specific to the idea of stress is cardiovascular reactivity to stress may also play a role, particularly among certain groups like Black Americans who are impacted by racial discrimination. And again, we'll talk about that a little bit more in class. Obesity, so having excess body weight, specifically a BMI greater than 3. This is a huge risk factor for heart disease. This risk is amplified if the person has abdominal obesity, which we've talked about earlier in this class. Also, if the person has lower levels of HDL or that good cholesterol and higher levels of triglycerides or one of the forms of bad cholesterol. Cholesterol in and of itself, as we mentioned earlier in this class, is a derivative of ingested fat. If a person's total cholesterol exceeds 240, that doubles the risk of heart disease. And in general, the higher a person's HDL, the better, but HDL under 40 is going to be a risk factor also. A person who's diagnosed with metabolic syndrome is someone who's at an increased risk for heart disease. We've talked about that earlier in this class, but if you need a reminder, the diagnostic criteria are listed on the screen. Tobacco use doubles the risk of a heart attack as well. Fortunately, though, this risk decreases after quitting, decreasing by about 50% in 1 year. Moderate use of alcohol may lower total cholesterol and raise HDL levels. So moderate alcohol use might actually be an okay thing as far as heart disease goes, although there are some gender sex specific findings there. So moderate use of alcohol may be more beneficial to women than to men, but in general, the data relating alcohol to heart disease seem to be more promising. Antioxidants can also prevent the oxidation of LDL and resultant damage to vessels as well as plaque buildup. So alcohol and antioxidants are two controllable things that, if used appropriately, can actually be beneficial versus everything else on this list is more like the risk of doing something. There are also some psychosocial factors. So everything we've kind of talked about relating to heart disease up until this point has been very biological in nature. So now we're going to shift gears a bit to more of the psychosocial pieces. So in the late 50s, these two researchers, Friedman and Rosenman, were puzzled by the notion that there were many coronary patients who didn't really fit the profile of the heart patient. They weren't obese, they weren't middle-aged men, they didn't have elevated cholesterol. And so they were interested in figuring out what else might be playing a role in them being diagnosed. And the thing that they looked at was personality. And this is actually the origin of the type A, type B personality. Most people are familiar with type A, the idea of someone who is competitive, strong sense of time urgency, maybe even hostile, and the idea of the type B, kind of the relaxed, not overly pressured, type of person, and you might even have an idea as to which of those two categories you fall into. But most people don't realize that the origin of the type A, type B goes back to heart research. And type A was the name that Friedman and Rosenman gave to their coronary prone behavior type, and type B was the contrast, kind of low risk type. Lately, though, researchers have wanted to hone in more so to what about type A makes them high risk? Is it the whole package, or is it specifically one personality trait within the cluster? And researchers have focused in on hostility, and researchers indicated that hostility is in fact the toxic core of the type A behavior, meaning it's totally okay if you're type A and you're very organized and you're competitive and you're timely and conscientious. What really makes type A dangerous is when a person is hostile, particularly if that person is a man. Hostility is a chronic negative outlook that encompasses feelings of anger, thoughts of cynicism and mistrust of others, and overt actions such as aggression. Two other psychosocial risk factors that I want to touch on are anger and depression. So these are two feelings. And the experience of these feelings, in addition to how we deal with these feelings, can directly contribute to a person's risk of developing heart disease. So anger is an emotion that we feel when we've either been provoked or we perceive mistreatment. The way I always explain it to my clients is that we feel anger when someone has crossed one of our boundaries or violated one of our values. And it's kind of our body's like security system alarm type of mechanism, where it's our body telling us like, hey, this person's crossed you, this person has crossed a line, like FYI, what do you want to do about it? And generally people tend to respond to anger in one of two things, in either an expressive way or a suppressive way. Expressive anger is anger out, so that would be someone screaming, versus suppressive or anger in is a person who kind of buries it deep down and ignores the fact that they're angry. About 20% of fatal heart attacks occur in response to an angry outburst in association with a lifetime pattern. So that doesn't mean you need to be afraid of losing your cool sporadically, but if you have a tendency to be angry chronically, and then you get into this big fight, this big blowout where you just kind of burst, that acute trigger can be what causes a heart attack. Kind of like what we talked about with angina. It's that combination of that chronic pattern with that acute trigger. But anger in, at the end of the day, isn't necessarily great either. Some research suggests that suppressed anger may be just as dangerous as expressed anger. And this relates back to James Pennebaker's theory of inhibition, which basically says that it takes energy to hold back emotions over time. And so we are activating our sympathetic nervous system, our fight or flight, to actively hold that anger in, which is very stressful on the body. And as you guys know, chronic stress increases the likelihood of developing new or worsened illness. So at the end of the day, what do we do with anger? The answer kind of goes back to appropriate expression. And I talked about this a little bit in chapter 5 when I talked about coping with stress. It can just be helpful to find a way to let an emotion out. So the answer is to let the anger out, but not in an over-the-top outburst kind of way. So you don't want to blow up, but instead you want to go for a run, you want to do some art, you want to wash the dishes, is the example I gave earlier in the semester. Just do something that serves as a healthy form for you to let the pressure out and the anger out on a regular basis. Depression is also strongly implicated as a risk factor in heart disease and metabolic syndrome, and the diabetes that we're going to talk about here in a moment. Depression can either be the after effect of a medical diagnosis or independent with its own causes, meaning that depression is dangerous whether the person just got a diagnosis of diabetes and now they feel depressed, or whether they were depressed before, but now they're also getting a diabetes diagnosis. Either way, estimates cite depression as a CVD risk factor that is commensurate with secondhand smoke. So it is definitely dangerous, and some of the explanations go back to the idea that depression seems to function as an inflammatory diagnosis, meaning that when we are depressed, our bodies are experiencing larger levels of inflammation compared to when we are not depressed. And that chronic inflammation is feeding into that atherosclerosis and arteriosclerosis that we talked about earlier. So how do these psychosocial factors promote disease? There are a couple of different hypotheses, a couple of different routes. These routes basically all boil down into either direct hypotheses routes or indirect hypotheses routes. So the first step is the psychosocial vulnerability hypothesis, which basically states that hostile, anxious, depressed adults tend to lead more stressful lives with low social support, and that this leads to poor heart health. So this is somewhat of an indirect hypothesis in that we've got people with certain personalities, certain emotional styles, and that as a consequence of these styles, these people are attracting more stress into their life. They're also deterring social support from others, and it's that stress and poor social support that is setting them up for poor heart health. The health behavior explanation states that these various psychosocial, emotional stressors contribute to poor self-care. So no exercise, poor diet, poor medication adherence, and this increases cardiovascular risk. So this is another indirect hypothesis that basically says people who are hostile, angry, even anxious or depressed tend to isolate themselves, and this leads to poor self-care. So this person's at home alone, they don't feel great, they're grouchy, and so they're not going to exercise, they're not going to eat well because they're by themselves feeling poorly. Or if they've been prescribed a medication, like one of the medications we talked about earlier, like a beta blocker, they might not be following through with the medication as prescribed. And so their cardiovascular risk increases because at the end of the day, their health behaviors are poor. Finally, the last model is a psychophysiological reactivity model. This model says that these various emotive states act slowly over time by increasing a person's immunity and increasing stress. As a consequence, we see physiological changes in the body, including increased pulse, blood pressure, and an increased ease of blood clot formation, and all of this stuff increases CVD risk. So this is going to be another indirect hypothesis, basically saying that we've got these emotional states which lead to decreased immunity and increased stress. These lead to things like increased heart rate, increased blood pressure, et cetera, and it's these physiological changes at the end of the day that increase heart risk. So all three of these are going to be good examples of indirect hypotheses. So in learning the difference between all of these, I would recommend, being able to kind of spell out the steps in each process and be able to point to what's happening in the middle that's leading to higher heart disease risk. Because the emotional states at the beginning and the end stage heart disease are the same across all of these hypotheses. The difference, though, is what's happening in the middle. So that's really what you guys need to retain in terms of studying this slide. It's not all bad, though. Positive psychology models indicate that psychological well-being promotes good cardiovascular health. in that people who feel good tend to adhere to health behaviors better, which is going to decrease heart risk. So that's kind of like the opposite of the health behavior explanation. So I include that on the slide as kind of like a silver lining, like it's not all doom and gloom. Doing the opposite of what these models state is healthy and leads to good outcomes as well. So why at the end of the day do people ignore the advice? I mean, at this point, heart disease isn't new, nor is the idea that blood pressure, cholesterol, exercise, diet, stress, all of this stuff leads to heart disease. So why is it still so prevalent? Why do people ignore the advice? At its core, there are those basic behavioral reasons that we talked about in chapter 6 that can kind of apply very broadly across different health behaviors and conditions. But more specific to heart disease, from an evolutionary perspective, our brains were really shaped to cope with an environment that's substantially different from our own. And so if we're focusing on more of a primitive, possibly like African type savanna, it would make sense if fat, which is typically scarce, were available. If there were a dead animal, for instance, that someone had killed, it makes sense that, this doesn't happen every day. Therefore, we should consume the animal, consume the meat while it's fresh and safe. And this is going to be a way to survive famine. And so we've kind of evolved to overeat when it comes to fats, to sugars, to higher calorie foods, because for our ancestors, those things weren't always available. And today in developing countries, those things aren't always available. So it makes sense to overeat when they are available. Higher degrees of cardiovascular reactivity also makes sense evolutionarily, because if you had a more reactive cardiovascular system, that would help you escape hostile threats more quickly. But today that contributes to a person basically overreacting physiologically to psychosocial stressors. And so we still carry these evolved food urges and hostile tendencies because adaptation and evolution is very slow. And at the end of the day, our bodies are more adapted to the environments of the past than the environments of the present. There are some things at the end of the day that providers can do for help. I put providers there in italics because these are suggestions that mental and physical health care providers can kind of help patients with. One thing is to control hypertension. For every 1 point drop in diastolic blood pressure, which is the number on the bottom of the blood pressure fraction, heart attack risk reduces by 2 to 3%. Some ways to do this are to decrease sodium intake to under 2,000 milligrams a day, to exercise more, and to aim to increase your good cholesterol levels through the consumption of unsaturated fats, and to try and lower BMI as well, but to also keep an eye on that waist to hip ratio, because remember, it's where the fat is that's more important than the overall amount of fat. Research shows that physically fit hypertensive individuals with high cholesterol have a lower heart disease risk than healthy people as far as blood pressure goes with low cholesterol who don't exercise, which kind of goes back to what I was talking about earlier with these markers versus genetics versus what a person's doing. And at the end of the day, it's what a person's doing that's more important than what their blood work is saying or what their family history is saying. So someone who's exercising but has a crappy family history is going to be healthier than someone who's not exercising who has a positive family history or a good family history. Leisure time physical activity is going to be better for folks with heart disease than work-related, because work-related can come with stress. And so if a person hates their job and is really stressed out, it doesn't matter if they're getting in, 10, 12,000 steps a day, that ultimately is contributing more harm than good in the way of stress. And so we would rather have a person work at a low stress job, even if they're not getting as much physical activity in, so that they can then engage in leisure time physical activity. We also want to encourage patients to reduce their total cholesterol. And one of the ways we can do this is to help people make it such that no more than 10% of their daily calories are coming from saturated fat. Saturated fats prevent that bad cholesterol from being removed from the body, as I mentioned earlier, which increases total cholesterol. Unsaturated fats are better choices. They provide the same calories, but lower total cholesterol by removing these LDLs. Carbohydrates should also not be used to simply replace saturated fats. Instead, we want to be actively consuming those unsaturated fats. One of the reasons for this is because carbohydrates can lower your LDL, but they can increase triglycerides and decrease HDL. Also, depending on the type of carbohydrate a person is consuming, they might be contributing to high blood sugar and blood sugar crashes, which are going to be impacting diabetes, which we'll talk about here in a minute. After a person has been diagnosed with cardiovascular disease, it's important to prevent recurrence. So after surgery, it's important to acknowledge cardiac patients as still being in a high-risk group who are in need of lifestyle adjustments. It's important to attend to a person's perceived social support, so not necessarily how much they have, but how much they feel they have. Their optimism versus pessimism levels, their hostility levels, involvement in community and religion. All of these things have been seen to be beneficial, so it's important to assess for and encourage these behaviors. It's also important to decrease stress after a person's been diagnosed, particularly after a person has had surgery as well. One such group that typically gets looked over in this scenario is a stay-at-home mom or a housewife. People or providers will frequently remember to remind people who are going back into a more traditional quote unquote job to like take it easy, but providers don't always think to remind people going back to household types of chores and work to take it easy as well. Because that is a form of stress as well. And stress following diagnosis, stress following surgery in particular, can lead to recurrence, which we don't want. Hostility, of course, is also going to be dangerous, which we've talked about already. Hostility increases the inflammatory response, and it also decreases a person's access to social support. And so it's important that if we're not able to help this person learn to cope, that we refer them to a resource to help with that. All right, so switching gears to diabetes. So diabetes is a diagnosis that is referring to people whose bodies have an inability to either produce or properly use insulin. Insulin is a hormone that helps to convert sugar and starch from food into energy. And it's a hormone that circulates in our blood to do this. So we're still dealing with the cardiovascular system as kind of the backdrop here. We're just dealing with a particular hormone within the blood that is doing a particular job, and that job is to convert sugars and starches from carbohydrates into usable energy. Diabetes in and of itself is also a risk factor towards developing heart disease. There's no real cure for diabetes right now, although it does seem that lifestyle changes may be able to reverse pieces of diabetes, and depending what type of person has, a person may be able to recover, but there's no like drug or something like that that is completely curative. The cause to a degree is a mystery, although we have been able to point to genetics as well as lifestyle factors as pieces that are definitely playing a role in contributing to the puzzle. This diagnosis impacts about 25 million Americans, or about 8% of the population, and it's the third most common chronic illness and the seventh leading cause of death in the United States. In the United States, African Americans, Hispanic Americans, and Native Americans are at a higher risk for diabetes than European and Asian Americans. And there's several different types of diabetes, specifically 3 types. So we've got type 1, type 2, and then gestational. So we're going to talk here for a moment about the differences between the 3. Type 1 diabetes was formerly referred to as insulin-dependent diabetes or juvenile diabetes, and this was because it usually developed in childhood or sometimes later in adolescence. But again, it's currently referred to as type 1. Part of the reason for the name shift is that type 2 was typically referred to as adult diabetes, but because of lifestyle change, we're now seeing adult diabetes in kids. And so it doesn't really make sense to differentiate them on the basis of age anymore. And so now we use type 1 and type 2. Type 1 is actually an autoimmune disease. It's when the person's immune system attacks the insulin producing cells of the pancreas, destroying them. And so the person doesn't have the insulin that they need to regulate those blood sugar levels. This individual becomes dependent on insulin as a way to regulate blood sugar, and the person uses insulin via either an injection or a pump. And there's some neat devices these days that can simply be worn on the arm to monitor blood sugar for a person versus a person having to continuously prick their finger to measure their blood sugar and then deliver their own insulin levels. Symptoms of type 1 diabetes include excessive thirst and urination, craving for sweets, weight loss, fatigue, and irritability. And these are all largely due to the body's inability to metabolize glucose, which is going to be the building block to sugar. And at the end of the day, the inability of the body to do this forces the body to feed off of its own fats and proteins as an energy source. Type 2 diabetes is, as I mentioned before, formerly referred to as adult onset or non-insulin dependent diabetes. This type encompasses about 90% of all diabetic cases. This type results from insulin resistance, sometimes also called glucose intolerance. This is a condition in which either the pancreas is failing to produce enough insulin or the body has become insensitive to insulin that is released due to decreased insulin receptors in target cells, such as cells of the muscles. So at the end of the day, the person is basically in this scenario through lifestyle, through consuming an unhealthy diet, typically a diet that's very high in simple carbohydrates. They're basically taking in more sugar than their body can produce insulin to deal with. And so the pancreas isn't keeping up with the person's diet. Or on the flip side, they're still consuming so much and the body can keep up, but it's almost like insulin starts to become kind of like old news and the body just kind of becomes less sensitive to it and more resistant. And so the insulin's being released as a consequence to what the person's eating, but it's just not having the same effect that it was before. Symptoms include frequent urination, irregular menstruation in women, fatigue, slow healing of cuts and bruises, dry mouth, and pain and cramps in the legs, feet, and fingers due to poor circulation. This diagnosis tends to be more common among women, people who are overweight, certain ethnic groups, the ones I mentioned earlier, and folks of a lower SES. Gestational diabetes is a temporary form of type 2 diabetes. So it's a temporary form of glucose intolerance that occurs in about 5 to 10% of women about halfway through pregnancy as a result of mother's inability to produce sufficient insulin. So in a nutshell, prior to pregnancy, the woman's body was able to produce enough insulin to keep up with the calories she was consuming. But now that she's pregnant and about halfway through pregnancy and taking in the recommended number of calories, depending on where you are in your pregnancy, should max out at about 500 calories a day. But it can be common for women to sometimes overeat during pregnancy. And so basically the body could keep up with the caloric intake before pregnancy, but now that the mother is consuming more, the pancreas can no longer keep up. So it's kind of this temporary form of type 2. Usually this goes away after baby's birth, but women who have gestational diabetes have a greater risk of later developing type 2. And this is because they were kind of on the line to begin with, which is why pregnancy pushed them over the line. Women giving birth to babies weighing more than 9 pounds are also at an increased risk of type 2 diabetes. The blood sugar problems relating to diabetes are hypoglycemia and hyperglycemia. Hypoglycemia is going to be low blood sugar versus hyperglycemia is going to be high blood sugar. And a lot of this has to do with the type of carbohydrate that a person is consuming. Complex versus simple carbohydrates help to prevent blood sugar spikes. Complex carbohydrates are more kind of carbs in their original form. So think kind of whole grains, brown grains versus bleached white processed grains. Complex carbohydrates, because they're left in their original form, they take longer to break down, they're less sweet, versus simple carbohydrates are typically delivering more sugar, and beyond that, they're very easy to break down, and so they contribute to these huge spikes in blood sugar, but then these crashes later on. An estimated 50 to 75% of individuals with diabetes develop one or more long-term health complications due to these difficulties regulating blood sugar and regularly having blood sugar that's too low or too high. These complications include arteriosclerosis, adult blindness, end-stage kidney failure, memory impairment, loss of pain sensitivity or circulation to the extremities, which can contribute to the amputation of things like toes and feet. Causes of diabetes include obesity. 30% of overweight people have diabetes, and 85% of those who have diabetes are also overweight. Fat cells also play a role in desensitizing muscle and liver target cells to insulin. So fat cells kind of play a role in this phenomenon of insulin starting to become old news to the muscle and the liver. So insulin's still being produced, but the muscle and the liver basically become less responsive, contributing to that type 2 type. An overactive immune system can contribute to diabetes. Genetics and environmental factors may also play a role. Specifically, the Western diet, highly processed, high-fat, high-calorie foods contribute to diabetes. Ethnic groups that follow such diets are going to be at a higher risk of diabetes. Beyond that, more of a sedentary lifestyle with increased TV time is also going to be a risk factor in type 2 diabetes. So many of the risk factors we talked about earlier with heart disease. Stress can also be a precipitating factor, particularly for someone with type 1. In terms of preventing and treating diabetes, the Diabetes Prevention Program has shown that lifestyle interventions to lose weight and increase physical activity have reduced the development of type 2 diabetes by almost 60% over a 3-year period of time, and the reduction was even greater, closer to 70% in older adults over the age of 60. Self-management is crucial in the treatment of diabetes, which is generally accomplished via lifestyle modifications, which include diet, weight management, regular exercise, and insulin injections if needed in the type 2 type. The goal of treatment is glycemic control or control of blood sugar, so keeping blood sugar at stable, healthy levels. Researchers have also consistently found an inverse relationship between self-management and blood sugar, meaning that the more you self-manage, the lower your blood sugar is. As far as what psychology brings to the table, knowledge, beliefs, and behavior of patients strongly affect ability to manage diabetes and its health impact. So when patients know what's going on, that helps them manage better. When people believe that there's something they can do about it, they're more likely to do that. And when they follow through that knowledge and beliefs with actions, we're more likely to see a positive impact. So again, this speaks to the importance of, even if you're thinking about going into a mental health profession versus nursing or working as a PA or a physician or whatever, it still is important to know about the mechanics of things like heart diseases and diabetes, because by being able to help educate your patients and increase their knowledge base, you can make them feel more confident about what it is they can do and increase the likelihood of them doing something about their diagnosis. Mental health professionals can also help patients grapple with the shock, denial, anger, and depression that might come with the diagnosis. And this can be the first step towards consistent self-management and acceptance of illness. Even after accepting illness, many patients may still struggle with illness intrusiveness, or the degree to which the illness is disruptive in their lives. And so coping skills and social support are crucial here. So teaching those coping skills and encouraging social support. And again, even if you're thinking about going into more of a physical healthcare setting and you might not really be in a position to do more extravagant coping skills, you can still be informed as to the role these things play in diabetes, referring patients to mental health care support, or simply encouraging social support. That's a really simple thing that you can talk about in a couple of minutes with a patient, maybe even prepare YouTube explanatory style videos, as I talked about in an earlier lecture, and kind of help patients in that way. Blood glucose awareness training, which is basically kind of teaching people to monitor their blood sugar levels and what to do at different levels. This has been associated with improved control of blood sugar and fewer complications. Research has also indicated that depression, anxiety, and eating disorders are also prevalent among adults with diabetes, more so than among the general population. And so if any screeners are kind of alerting to the presence of these diagnoses, the person should definitely be referred to a professional for psychotherapy. One final intervention that I like to share with class, and this is something more applicable to certainly the mental health care side of the equation, but something that you could even incorporate in some fashion, depending on how much time you have with patients in a traditional healthcare setting, is the idea of benefit finding. Benefit finding, it's kind of like just finding the silver lining. In any situation there, if you look hard enough, there's typically something good that's come out of the situation, even if it's a really scary diagnosis like diabetes or cardiovascular disease. So as you look through this, you see that basically all you do is you kind of hand this to the patient and you have them fill in whatever the diagnosis is at the top. So this isn't specific to diabetes, I'm just kind of presenting it here. So having had diabetes, and then you have them indicate whether each of the following statements does not apply to them at all or extremely applies to them. So having had diabetes has shown me that all people need to be loved, has led to me being more accepting of things. Having diabetes has made me a more responsible person. Having diabetes has helped me budget my time better. Having diabetes has taught me to be patient or to control my temper. So this can help patients just kind of start thinking about maybe some of the positive things that came out of this. Like maybe this is what helped them turn their life around and start valuing physical exercise, or maybe this helped them become closer with their family or learn to be more responsible, especially for talking about diabetes and having to monitor blood sugar. So again, this is a really great intervention, and you can use the full worksheet version, or you can just kind of internalize that idea of helping someone to find the silver lining, and just kind of incorporate that into conversations with patients. And again, pretty straightforward intervention, something that can definitely be adjusted to suit either a full, 45-minute mental health session, or even adjusted to suit like a 5 to 10-minute consultation type meeting with a patient in like a healthcare office. Alrighty, so that is all that I have for you guys about the cardiometabolic conditions. So you guys should be, aware of the basic anatomy and phys that I talked about in this class. If you've taken other more in-depth classes, you definitely don't need to know the anatomy and physiology at that level, simply at the level I presented it. You should also be aware of the biopsychosocial underlying factors behind all of these diagnoses, as far as, in addition to, sorry, I'm slurring over my words, the long lecture, in addition to like how these things are diagnosed, how they're treated, and some of the psychosocial pieces to keep in mind as far as treatment goes as well. You'll find the additional readings and videos and things like that on As You Learn, so just be sure to review all of that stuff, and we will have a good conversation next time we meet. All right, have a good one, y'all.